Today we are going to discuss here about Psychiatry MRCP Part 1 MCQs. Let's begin. So in previous video I haven't discussed MCQ number 20. So this video is from 20 till 28 MCQs. 55-year-old woman with bipolar disorder has seizures. She has never fitted before. Her husband reports had a 3 days history of tremor and seizures, nausea, vomiting, muscle twitches, bloody diarrhea before they boarded their flight home from a holiday in Egypt, which is the single most likely cause. Acute confusional state secondary to acute infection, lithium toxicity, pulmonary embolism, thyrotoxicosis, traveler's diarrhea. So guys, patient is bipolar disorder and she developed seizure, and 3 days before she had nausea, vomiting, diarrhea and muscle twitches. So this case look like patient on lithium. So this is a lithium toxicity. Okay, this happened due to lithium toxicity. Now 74-year-old woman became increasingly confused, age 74, period of 6 months before formal diagnosis could be made. She died of a heart attack. She already died of heart attack. Provisional diagnosis of Alzheimer's dementia was made, and her daughter would like to know if this was the case. She agrees to an autopsy. For autopsy, which single neuropathological finding would be most likely confirm the diagnosis? Cytoplasmic inclusion body, extracellular neurofibrillary tangles, extracellular senile plaques, knife edge atrophy, or Pick's bodies. So guys, we are going to discuss all options. So on autopsy we find extracellular senile plaques. Let's discuss. Extracellular senile plaques found in Alzheimer's dementia and can also be found in normal aging brain some extent. Amyloid formed abnormal metabolism, amino acid inclusion bodies or cytoplasmic aggregates in substance, usually proteins. Cytoplasmic inclusion body found in some viral infections such as rabies, smallpox. So one MCQ more I discuss here. Cytoplasmic inclusion body seen in viral infection, and neuronal inclusion bodies found in Parkinson disease and Lewy body dementia. One more MCQ, neuronal inclusion bodies in Parkinson and Lewy body dementia. Whereas in Alzheimer there are intercellular neurofibrillary tangles, not extracellular. Intracellular neurofibrillary tangles, not extracellular. Okay, so hope it's clear. In cytoplasmic bodies in viral infection, inclusion bodies in viral infection, and neuronal inclusion bodies in Parkinson, intracellular neurofibrillary tangles and extracellular senile plaques in Alzheimer's. Whereas knife edge atrophy, global thinning cerebral cortex, frontal lobes in Pick's disease. So I hope guys till here it's very much clear. Now move on next MCQ. 68-year-old woman was admitted 24 hours earlier with headache, nausea and anxiety. She now has new tremors, sweating and become agitated, rude to staff, demanding her medication. It is believed she is showing signs of drug withdrawal. Which is the single most likely medication responsible for this? Fluoxetine, levothyroxine, lorazepam, QTPin, zopiclone. So guys, this symptoms, aggression, tremors, sweating, agitation, nausea, headache, is mainly due to short-term drug withdrawal, that is lorazepam short acting. Okay, consultation of symptoms about her classic benzodiazepine withdrawal. Lorazepam, one of the shortest acting benzodiazepine, if taken regularly and for a long enough period to develop dependence withdrawal, would be expected to seen if it were suddenly. Now 25-year Sorry, 25th question. A retired 76-year-old man with UTI, septic and dehydrated. He has become aggressive, agitated, demanding to leave. The emergency department says has to go to work, which is single most appropriate management. 76-year-old man, history of UTI, present with UTI, septic and dehydrated. Aggressive, agitated, demanding to leave emergency department. He says he has to go for work. He is already retired. No work is required. So, what is your best answer? Admit him to medical ward under the Mental Capacity Act. Ask him to complete a discharge against medical advice form. Detain him under section 5(2) of MHA. Discharge him with course of antibiotics with GP, general practitioner follow-up. Organize an MHA. Guys, UTI with septicemia and dehydration, he is aggressive, so he is not fully conscious, not oriented. He is in acute confusional state. So in this situation, admit him to the medical ward under the Mental Capacity Act. Okay, don't discharge him on antibiotics. Why? Because there is life-threatening situation. So septicemia, he need admission. 40-year-old man was an alcoholic and heroin addict. He has now completed an alcohol detox, is receiving methadone maintenance treatment. He has an established diagnosis of emotional unstable personality borderline type. He would like to continue with his methadone treatment and to reduce risk of alcohol relapse. He is particularly concerned about alcohol cravings. Psychosocial intervention is initiated. Which is single most appropriate medication to prescribe? Which single most medication reduces craving? Camprosit, disulfiram, fluoxetine, haloperidol, naltrexone. So guys, fluoxetine antidepressant, not reduces craving. Haloperidol antipsychotic, not reduces craving. Naltrexone we can use, but this also does not reduces craving. Disulfiram not reduces craving. If you drink alcohol with disulfiram, it causes very severe symptoms like vomiting, anxiety, sweating, etc. Acamprosate is anti-craving agent here. Now, little bit discussion. There is a good evidence of camprosate efficacy is preventing alcohol relapse. This is an glutamatergic NMDA receptor antagonist. Because alcohol dependence and alcohol withdrawal are associated with hyperglutamatergic system. Acamprosate effectively reduces this. So hope it's clear now. 79-year-old man has short-term memory loss, non-troublesome visual hallucination, and had some stiffness and tremor for 9 months. MMSE2 score 23:30. What is single most appropriate medication to show cognitive decline? So guys, firstly you have to understand what is diagnosis here. Memory loss indicates Alzheimer's, 79 year, but visual hallucination we find in not in Alzheimer's, in Lewy body dementia, and his MMSE score little low. So how to treat Lewy body dementia? By rivastigmine. Okay, rivastigmine has the biggest body of evidence currently for use in Lewy body dementia. Donepezil is an acetylcholinesterase inhibitor prescribed most readily for patient with Alzheimer's dementia. It would be reasonably choice, but it is not the first option as it patient symptom point to a diagnosis of Lewy body dementia. Galantamine is another anti-cholinesterase inhibitor that can be used in dementia. It is more expensive than donepezil and rivastigmine and tends to be used less as first-line treatment. Levodopa would primarily use treatment the motor symptoms of Parkinson and has no effect on memory. Memantine recommended by NICE to be used for treatment of moderate to severe dementia. It may also used in patients who cannot tolerate other anti-dementia medication due to cardiac arrhythmias, as it is safer option. So guys, I explain here all options. Now, an 18-year-old woman took an overdose 5 hours ago. Blood test reveals serum paracetamol level above the treatment line, which is the single most appropriate treatment to initiate. Activated charcoal, alkaline diuresis, gastric lavage, IV Pebrinex, IV Povolax. So guys, in this situation, antidote of paracetamol, that is acetylcysteine, we use IV Povolax. Most appropriate treatment is IV Povolax. Plasma paracetamol concentration should be measured in all conscious patients with history of paracetamol overdose. Suspected paracetamol overdose as recommended by ToxBase, they should be taken in patient with presentation consistent with opioid poisoning in conscious patient with history of collapse. Where drug overdose is possible diagnosis, plasma paracetamol should be measured for risk assessment not earlier than 4 hours and no later than 15 after ingestion. As a result, non-reliable outside the time period, IV acetylcysteine Povolax should be considered as treatment of choice for paracetamol overdose. So guys, I hope till here it's clear. Thank you.